Now let's move on to some of the hereditary hyperbilirubinemia syndromes. So these syndromes are a collection of autosomal recessive genetic conditions that either affect your ability to conjugate bilirubin or your ability to excrete bilirubin. And so I'm going to break them down into two different categories. Here's our conjugation disorders, and here's our excretion disorders. And something I want to mention is that the classic hyperbilirubinemia syndromes are the first two on this list, this Gilbert's and Crigler-Najjar, and then Dubin-Johnson versus Rotor. I'm going to add these physiologic. This isn't technically an autosomal recessive condition. This is actually just, as the name suggests, part of our natural upbringing. It's physiologic. And then this biliary atresia, it's not technically an autosomal recessive condition either, but it'll cause some of the same findings that you'll see in these other two. So that's why I lump them like this. I think it'll be easy to understand as we go through this. So let's start by talking about all of the conditions that will affect the conjugation of bilirubin, starting with Gilbert syndrome. So in Gilbert syndrome, the pathogenesis is mildly decreased UDP glucuronosyl transferase. I'm just going to call that UGT. So mildly decreased UGT activity, which will lead to impaired bilirubin conjugation. And so if you remember from earlier in our liver section, we had all of our unconjugated bilirubin can be converted by the liver into conjugated bilirubin. And that's done by that UGT enzyme. And how this works is that, remember that our unconjugated bilirubin is water insoluble. And so what's going to happen is that UGT can actually add on a glucuronic acid, which is a water-soluble compound. It can add that onto this unconjugated bilirubin and create a more water-soluble compound, namely conjugated bilirubin. And if your bilirubin is conjugated and it's water-soluble, then it can enter that water-soluble bile and actually get excreted. So that's the whole point of this process. In Gilbert's disease, what's going to happen is that our UGT activity is mildly decreased. So it still works, but it's just a little bit lower activity than we'd like. And so if we have that, I'll explain what that'll actually cause in just a moment. Most of the time, Gilbert's is asymptomatic. You're just going to find a mildly elevated unconjugated bilirubin if you did lab studies. And going back to our slide that we just talked about, because this is mildly decreased, the UGT activity is mildly decreased, what can happen is that you can get a buildup of unconjugated bilirubin. And this usually doesn't happen all the time. It's more often you'll notice it during times of stress. So if somebody's stressed, like they're sick or they're studying for a big exam or they're fasting, what's going to happen is that you're going to get more of a buildup of that unconjugated bilirubin, and it might present clinically with some signs like jaundice you might see because of that bilirubin buildup. Fortunately, this is a benign condition, so you just have to reassure them and let them know about the condition moving forward. The more significant condition and essentially the more extreme version of Gilbert's disease is Crigler-Najjar syndrome. And so Crigler-Najjar is either significantly decreased or absence of that UGT enzyme. So now if we go back to our framework we talked about before, what's happening here is that we'll just assume we have absent UGT activity. And so if we have absent, then you're going to get obviously significantly elevated unconjugated bilirubin as well. Now, because you have zero way for your unconjugated bilirubin to convert into conjugated, this is going to present a lot more severely and a lot earlier in life. You're usually going to see it in infancy. You're going to notice significant hyperbilirubinemia, especially unconjugated, which will give you jaundice. Another thing I want to mention here is that unconjugated bilirubin can end up going into your brain, and that can cause a really, really dangerous condition called kernicterus. So kernicterus is a potentially fatal deposition of unconjugated bilirubin in your brain. And what'll happen is that that unconjugated bilirubin gets into your brain, and it's a neurotoxin. So it can cause irreversible brain damage. And like I said, it can actually cause death. And they want you to know where the unconjugated bilirubin preferentially deposits, and it's in the basal ganglia of the brain. So why does this happen? So the blood-brain barrier is lipid soluble. And remember that unconjugated bilirubin is also lipid soluble. Remember how it's water unsoluble. So it's a water insoluble, which actually makes it lipid soluble. And another thing I want to point out is that the blood-brain barrier is less developed in newborns. And because of that, they have a higher risk of kernicterus than, let's say, if I had unconjugated hyperbilirubinemia, my risk of kernicterus would still be quite low. So let's go over how that works. So if this is our blood, we have epithelial cells and we have podocytes. And then if it can make it past both of those, then it can make it into our brain. That's our blood-brain barrier. So remember that this is lipid soluble. So if you have some sort of hydrophilic water soluble substance and it tries to get in, your blood-brain barrier is going to send it back into the bloodstream. On the other hand, if you have hydrophobic substances like unconjugated bilirubin, that can actually diffuse across and make it into the brain. So like I said, unconjugated bilirubin is lipid soluble. So it's able to cross this and make it into the brain. And as I mentioned before, it prefers depositing in the basal ganglia of the brain. And something I do want to point out again, just to make sure we understand, because the blood-brain barrier is less developed in newborns, they have the highest risk of developing kernicterus. If you have a unconjugated hyperbilirubinemia in adults, let's say somebody has Gilbert's disease and they're going through a stressful episode where their unconjugated bilirubin is mildly elevated, it's very, very, very unlikely to cause kernicterus because their blood-brain barrier is developed enough to where it's not going to allow some of these lipophilic substances like unconjugated bilirubin into the brain. So obviously here we're talking about Crigler-Najjar, which is an unconjugated hyperbilirubinemia that's happening very, very early in life. It's causing kernicterus. There's two subtypes. They mention on almost every resource I've seen, but I haven't really seen it tested. So the type 1 Crigler-Najjar is the most severe form. The type 2 is the less severe form. And the only thing you need to know is that for type 2, there are two treatments you can use. You can use this phenobarbital and clofibrate. Again, I don't know how important this is for you to recognize. I remember it, that the type 2 being not requiring two drugs, or you can use two drugs to treat type 2. And I remember the BI, as you know, like bicycle means two wheels. So I remember that bi and phenobarbital as one of my drugs, and then clofibrate. I guess you just have to remember that on your own. And to treat this, as you can do with other conditions that cause unconjugated hyperbilirubinemia in newborns, you can either do a plasmapheresis or you can do phototherapy. And both of these, what they'll do is they'll increase the water solubility of unconjugated bilirubin. Notably, that none of these treatments actually conjugate bilirubin, and they will try to trick you on a test, especially with the next condition we'll talk about. So that's Crigler-Najjar syndrome. I want to discuss physiologic neonatal jaundice because it has some of the same mechanisms that we just talked about for the other conditions, actually. So this is not an inborn genetic mutation. What's happening here is that when we're born, all newborns have some sort of UGT deficiency, and it's temporary. It takes a little bit of time, on the order of a couple weeks, in order for your UGT enzymes to be working as well as they need to appropriately conjugate all the bilirubin in their blood. And so, normally speaking, you'll find this either in a newborn who's asymptomatic, who you're just giving them a normal bilirubin screen, and if you notice an elevated unconjugated bilirubin, or you might notice this symptomatically with jaundice. And again, a complication of having too much unconjugated bilirubin in your system will be Kernicterus. And you're going to treat this, if you need to, you're going to treat this with phototherapy. And what that'll do is that'll increase the water solubility of unconjugated bilirubin. But notably, it does not conjugate your bilirubin. And usually the prognosis is very good. Like I said, this is physiologic. It should recover. And as your UGT activity starts to work more toward baseline, your symptoms will resolve. And something, I don't know if I pointed it out well enough here. I just want to clarify on a test question, how they're going to present this. They're going to say, hey, you got a newborn who's got jaundice. They're going to show you the lab value where it has an elevated unconjugated bilirubin. They're going to either tell you what's going on and you just let them know it's physiologic neonatal jaundice, or they'll kind of take it a step further and they'll say, hey, or they'll ask you what complication can happen. So you'll have to know that it can be Kernicterus. They might ask you where in the brain this will happen. You'll have to say the basal ganglia. But the thing I wanted to emphasize even more is that sometimes they'll give you this whole picture and they'll say they're going to treat it with phototherapy. And they're going to say, what's the mechanism of action of this treatment modality? And one of the answer choices will absolutely be this treatment will end up conjugating bilirubin. And that will be the wrong answer. You have to pick it that it increases the water solubility of unconjugated bilirubin. So just keep that in mind. They do like this question quite a bit. Now we can move on from the conjugation disorders and focus on disorders of bilirubin excretion. So let's start with Dubin-Johnson syndrome. So the pathogenesis of this, as I alluded to, is defective bilirubin excretion from the liver. Keep in mind that the hepatocytes are still able to conjugate the bilirubin. They just can't get it out of the hepatocytes and into the bile duct like it should go. So if we look at our framework here, we've already talked about in Gilbert's and Crigler-Najjar and in physiologic neonatal jaundice, our big problem revolved around this UGT enzyme. And because the UGT wasn't working as well as it needed to, we always ended up getting a significant amount of unconjugated bilirubin in our blood. What's happening in these excretion disorders is that this UGT enzyme is working just fine. The real problem is that we're having trouble, once we've formed this conjugated bilirubin, we're having trouble getting it into our bile ducts and excreting it. And so again, this will usually be asymptomatic, and sometimes you'll be able to see elevated conjugated bilirubin on labs. And if we go back to our framework here, if this is blocked off, if this X is blocked off, it shouldn't surprise you that you're going to get an increase of conjugated bilirubin, which is different than the unconjugated hyperbilirubinemia that we've been seeing in Gilbert's, Crigler-Najjar, and physiologic neonatal jaundice. And there you can see this conjugated bilirubin can get detected in the blood. My mnemonic for Dubin-Johnson, I always think of this as, I'm a San Francisco Giants fan, and I always remembered this for, we had Mauricio Dubon on our team for a little bit, and I just picture this Dubin-Johnson. This is like a matchup between pitcher Randy Johnson and Mauricio Dubon. So what's happening here, how I picture this in my head, is that the baseball is still getting thrown to the batter. So we're still getting it conjugated. So from the pitcher to the batter, and then Mauricio Dubon just hits one out of the park. And so the bilirubin ends up all the way over here into the bloodstream. So that helped me remember that the Dubin-Johnson, you do actually conjugate it before it goes into the bloodstream. And what you'll find in Dubin-Johnson syndrome is that if you look at the liver, let's say you did some sort of like cholecystectomy or appendectomy, and you just happen to look at the liver, you'll notice the liver is darker in color. And you'll remember that dark liver for Dubin-Johnson, the D in dark and the D in Dubin-Johnson coincide. And you don't have to do anything with this condition. It's a benign condition. You don't have to worry about it. Let's talk about Rotor syndrome now. So this is an even milder form of Dubin-Johnson. And again, it's just defective biliary excretion, but you can conjugate it just fine. So it's the same thing we just talked about as Dubin-Johnson. Where this isn't working, so you might get an elevated conjugated bilirubin. And this time, instead of having that dark liver that we saw in Dubin-Johnson, the liver color is regular. It's your normal liver color. So you remember The R in Rotor Syndrome will remind you of the regular liver color. Let's finish this off by talking about biliary atresia, which again, technically isn't an autosomal recessive condition, but it will present very similarly to what we just talked about. So what's happening in biliary atresia is that you have, for whatever reason, you have destruction of your bile ducts. And so that's going to cause impaired bilirubin excretion. So on laboratory findings, just like in Dubin-Johnson and Rotor syndrome, you're going to find an elevated conjugated or direct bilirubin in the blood. And so let's find out what this looks like. Again, if our bile ducts are getting destroyed, if we have atretic bile ducts here, then again, you're going to not be able to conjugate you're not going to be able to move this conjugated bilirubin for excretion, so you'll get a conjugated hyperbilirubinemia. So for any time you have any sort of bilirubin in your system, whether it's conjugated or unconjugated, you can get jaundice. You can also get dark urine and acolic stools, and I'll talk about why this happens. So in the case of jaundice, we know that anytime you have any sort of bilirubin in your blood, you'll end up with jaundice. Dark urine, we've talked about before. If you ever have conjugated bilirubin entering your bloodstream, conjugated bilirubin is water soluble, and so that can actually get excreted in the kidneys and show up as dark urine. And then finally, acolic stools or pale colored stools. You need bilirubin in your GI tract in order to provide that brown pigment in the stool as stercobilin. And if no bilirubin's making it to your GI tract, you're going to get pale stools. And just as a heads up, technically this could happen in Rotor and Dubin-Johnson as well. Anytime you have conjugated bilirubin in your blood, you can have dark urine. And anytime you don't have enough conjugated bilirubin in your GI tract, you can also get acolic stools. They don't really emphasize that on tests though for those two conditions. I would really just remember, asymptomatic elevated conjugated hyperbilirubinemia. And then just remember that Dubin-Johnson has the dark liver and Rotor syndrome has the regular liver. Taking a step back now, let's go back to biliary atresia here. So we've mentioned these three symptoms. A symptom that is notably absent in any of these conjugated hyperbilirubinemia is Kernicterus. You will not get Kernicterus in any of the excretion disorders that we just discussed. The reason why is that our blood-brain barrier is lipid soluble. So hydrophobic substances like unconjugated bilirubin can diffuse across this barrier. Now, hydrophilic substances like conjugated bilirubin get denied entry. So it doesn't matter how much conjugated bilirubin you have in your system, in Dubin-Johnson, Rotors, or biliary atresia, you have a very low risk of Kernicterus because these water-soluble compounds cannot diffuse across your blood-brain barrier. And you need to treat this with surgical correction because otherwise you're going to have the same problems coming up over and over again, and you'll never be able to excrete your bilirubin as you should. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.